here at Kaiser LA. I've been here for about 17 years now. And thank you for inviting me to give you a presentation on the neurosurgery professional practice lecture specifically on post-op expectations. It's a lot to cover, so I will try my best to kind of, point out some details, what you guys look for. But certainly you guys should get a copy of this lecture as well. Um, so we're going to go ahead and start now. So this first slide, we first want to talk about and think about what postoperative goals for discharge optimization is. As stated here, we want to be able to detect surgical and medical instabilities early, any symptoms that patients experience, and we want to be able to detect that early so then we can manage early. We want to start mobility early as well. Rehabilitation staff like PT, OT, speech, they want to do their assessments, treatments, and then come up with a recommendation and even sometimes teachings to the patients and the family. We want to also identify DME, which is medical equipment such as front wheel walkers or hospital beds or commodes or shower chairs. We want to be able to identify the needs of these things early too, so we can prearrange for delivery, right? We want to also normalize any nutritional intake. When we send people home, we want to make sure that they are able to eat and drink. If they don't or cannot eat and drink, by mouth, like, do we have to do NG tube, or if not, a G tube or a PEG, and those type of arrangements also needs teaching as well. We want to also able to get our patients to have a bowel movement. Although it is not a definite criteria for discharge, from a neurosurgery standpoint, we really prefer them to have pass gas. However, I do find it easier if they can have a bowel movement in the hospital, just to kind of get their GI systems going so that they don't have to deal with constipations at home, because once they get home, if they can't poop, it's coming back into the ER, right? So that's a readmission. So we want to, help the patients kind of normalize their GI patterns, okay? Urine regimen, we also want to be able to help patients be able to urinate by themselves. If they can't, for whatever reason, because they have urinary retention, we need to educate them how to either in and out cast or do the Foley catheter care. So we want to be able to teach patient and family early on as well. For DVT prophylaxis, typically when patients are moving around and when they're going home, they don't really need a subQ heparin or Lovenox subQ for DVT prophylaxis. Mobility is, always encouraged. So we don't need to send people home with DVT prophylaxis. However, we just, want to make sure that if, like, let's say they have a DVT here in the hospital, like, what is the management of that? We have to educate patients as well as family, in terms of elevate the feet, or if they have to do some kind of injections for the DVT treatment, or even the pills, so we have to educate people with that. Also, wound and drain care for education. So typically we don't send people home with a lumbar drain or wound drain. Sometimes we do, well, actually, let me take that back. Plastic surgery on some procedures we do with plastic surgery, they're okay with sending these lumbar drain and JP drains home with the patient. So we just have to teach the patients how to record, or measure the output, record, and then they will follow up a plastic surgery team. But from a neurosurgery and spine surgery standpoint, we don't typically send patients home with it. We actually take it out before they leave to go home. And then lastly, patient and family updates. We want to make sure we communicate with them on a daily basis so that everybody's on one page. For me, I feel like a lot of the fear is the unknown. So if we educate family and we tell them, we communicate with them, they're less fearful. Okay, so let's start off with procedures, and we're going to go from head to toe. So we'll start with craniotomies and burr hole procedures. So here's a picture of what a craniotomy is. And this is basically, we do this procedure is basically we make an incision in the scalp, and then we take the skull out, okay? And then we have, this is called the dura, which is the membrane of the brain, and we carefully dissect it and cut it out. And then here's the brain, and here's our blood vessels, right? So that's called a craniotomy, is the removal of the skull with the brain exposed. And burr holes are smaller, like maybe a quarter size. And usually those bones are not replaceable. Like we just drill them with it, electric drill. So we just put a titanium plate over it. When we do put the skull back on, they are secured with titanium plates and screws. They're okay with MRIs in the future, and they're not going to set off any security alarms, okay? Here's some indications here about why we do craniotomy. Hematomas such as epidural hematoma, subdural hematoma, intracranial hemorrhages, tumors. You guys have seen DBS, which is deep brain stimulator, which they're actually more burr holes than craniotomy. Some strokes, and we'll talk about craniectomies, which is basically removal of the bone. And then you either put it or house it in the abdomen area, which I have slides later on to talk about a little bit more about that. Infections, trauma, skull fractures, epilepsy. These are just few, indications here. So here's some ICU post-op care orders, and as well as NSU post-op care orders. I did both ICU and NSU orders set so you guys can kind of compare and contrast. Typically craniotomy and burr hole patients do go to ICU after recovery, okay? So they do spend about maybe a day or two there in the ICU setting where, Q1 neuro checks are performed, vital signs checks, systolic blood pressure always have to be less than 140, FYI, okay? And the reason is because when you go too high, sometimes it can burst the blood vessels due to the surgery, the actual cut. So we just don't want the blood pressure to go too high. Typically with cranial pathologies and conditions, we want to avoid heavy sedations, and that's at ICU and NSU as well. In ICU, we have subgaleal drains, subdural drains, or sometimes even external ventricular drains, EVD, as well. And I also have another slide later on, and I can talk about the different type of drains for you later. But by the time these patients get to NSU, to you guys on the floor, the only drain they should have is subgaleal drains, which are drains that are over the skull, but underneath the scalp, okay? If you have any drains that communicates underneath the dura, called a subdural drain, which is underneath the dura but above the brain, or extraventricular drain, which is the catheter into the ventricles, okay? These patients should not be on the floor because it needs a lot more attention in measuring the output of these drains. So the floor nurses, you guys end up having to take care of a lot of more patients, right? There's a difference of patient-nurse ratio. So if you have a subdural or a EVD drain, they should stay in ICU, okay? PTOT, early mobility, can start in ICU. They continue on the floor. We do DVT chemical prophylaxis too, continue the oral diet or nutritional status. Depending on the drain, the head of the bed might be different compared to NSU. So for subgaleal drains, the head of the bed could be at 30 degrees. That's okay. But when you have a subdural drain, head of the bed should be flat, 0 to 10 degrees. When it's EVD, the head of the bed is at 30. So there are variations with the type of drain versus the head of the bed elevation as well. Okay, so you should, as nurses, you guys should look for these specific orders. Okay, we don't expect you guys to know and automatically, so don't assume. Always get your providers to write clear orders for you guys. We start bowel urine regimen, remove the Foley if we can, um, you know, out of bed with assistance. Initially in ICU, PTOT starts, but maybe sometimes by the time they get to you guys can do the ambulation before waiting for rehab. Obviously, cardiac monitor starts in ICU, and then by the time they get to you, they could be discontinued if the vital signs are stable, and then obviously labs. So those orders are continued from ICU to NSU as well. All right, so here's some expected symptoms. So people that have craniotomies, people can complain about incision pain. That can describe to be like headache. Sometimes depending on the incision, like the bifrontal cuts, they get really a lot of facial edema and even ecchymosis, like bruises around the eyes. And those are normal, okay? They're expected, okay? We typically already educate the patients about that. So by the time they get to you, the patients shouldn't complain to you so much. But some of the expected symptoms from craniotomy could be facial swelling, okay? The brain is a very awesome, as well as the spine too, all the nerves, the central nervous system is a very awesome anatomy because there are very eloquent areas of the anatomy and there are silent areas. So you can have a lot going on in a silent part of the brain and the patient will not exhibit any symptoms, okay? Or you can have relatively very little stuff issue happening at a very eloquent part of the brain, and then all of a sudden the patient exhibit tons of symptoms. So when I talk about expected symptoms, the symptoms really depends on where the location of the surgery is, okay? So like, for example, if we do a right subdural craniotomy, right, for a subdural evacuation, symptoms decline would be on the left side of the body, right? Right side of the brain controls the left side of the body. So you guys have to kind of think about symptoms, what to watch for. And I've had patients and even nurses that tell me, oh, the patient has right-sided, weakness, but then we did the surgery on the right side. So that doesn't really make sense, right? So we need to work up on that. Any symptoms that patients have still reported, still documented in your nursing documentations so that the providers will read it every morning, okay? Any craniotomies or burr hole, seizures always can be a risk. I always tell my patients seizure is a symptom of a brain. Just like a cough is a symptom of your nose and throat, right? So if you get bronchitis or pneumonia, sometimes you can cough and it's one of those involuntary type of symptoms. So when something's going on in your brain, you can seize. So seizure could be a risk. Medication side effects and intolerances, be careful with those. If people gets constipated or, because they're taking narcotics, having a lot of narcotics can also cause urinary retention, right? So is that really part of a brain, symptom, or is that more medication side effects? So, be aware of what medications patients take and their side effects. Now, things to watch for when people have craniotomies or burr hole procedures, obviously neural symptoms decline, right? We talked about if the patient had a right craniotomy for subdural evacuation, make sure the left side is strong. They probably presented to the hospital with left-sided weakness, so make sure that doesn't get worse. If that, make sure that left-sided weakness gets better. Make sure there's no vital sign changes, right? Like tachycardia or pulse ox problems or even blood pressure problems, right? Right here we want to have blood pressure less than 140 with oral blood pressure medicine, okay? Now, seizure is a risk too, so make sure you watch for seizures. And then sometimes, there's all various types of seizures too. like zoning out, altered mental status, there's motor type, there's sensory type. So, just make sure you collect your information from the patients and report it, okay? When it comes to brain, when we keep the serum sodium goals at 135 to 145, their neurological deficits are more tolerable and more controllable. That's why we always look from a neurosurgery standpoint, we always check the sodium every morning. Because sometimes this 135 drops down to 131, all of a sudden they start having worsening of headaches. All of a sudden their left-sided weakness gets worse. And then once you correct it, they all of a sudden get so much better. So I always tell people, eat your salt, put salt in your diet. This is probably very few times where your provider is telling you to eat a lot of sodium, because we want to keep that sodium range at 135 to 145, okay? We do use sodium, and we can talk about that later, to kind of help with cerebral edema, like when people have big strokes, in which that serum sodium is 145, it's typically 140 to 150, and they're on hypertonic saline. And there's, additional protocols for that too. So just make sure that you get orders for clarifications, okay? Again, here we talked about subgaleal drain. Make sure that you record the output. I know that it is difficult for you guys to, record the output every 1 hour or even 2 hours sometimes, but be aware that if the JP drain is full, then it's not working. And then you also have to be aware the output consistency. Is it serosanguinous, or is it more like CSFE, or is it more blood, right? So we need to know, as providers, neurosurgery providers, we need to know that as well, okay? And then obviously make sure that there's no wound problems, because sometimes, especially with really big incisions, and if the patient has coagulopathy issues, that incision might ooze, like bleed a little bit, in which we need to know that, because usually if stuff is coming out of the wound, bacteria can go back in, so we don't want to have any risk of infection. Okay, so next procedure is called transnasal transsphenoidal adenylomectomy. In short, we say abbreviation TNTS. And this is basically to remove any pituitary mass. And there's tons of masses that can happen in this area, but the way that we do surgery is very similar. We basically go through the nose with the camera system. At Kaiser LA, we perform this surgery with the ENT doctor, head and neck surgeon, typically is Dr. Lim. So he does the exposure for us, and you go through the nose with the camera system. Once you get into the pituitary area, the neurosurgeon would go and take out the tumor. And so it's a really beautiful pathology, when we see inside with the camera system. Around the pituitary, it's right behind your nose, crucial structures such as the optic nerves, the optic chiasm, the pituitary gland, it's all there. And each of those structures have their own symptoms, right? That can be bad for the patients too, right? If you can imagine optic nerves, optic chiasm, people will have, vision problems, either half blind or quarter blind, or pure blindness. So in this type of procedure, you need to watch out for those type of symptoms, vision disturbances, right? You might also double check the hormones too, because they're around the pituitary area, in which, let's go to the next slide. Oh, this slide I just want to show you real quick. This is a nasal packing that ENT and doctors put in there to kind of like use it as a pressure dressing. Some of them have a deeper absorbable nasal packing in there, which doesn't come out. And then there are some that they put in with a suture tied outside, and that gets removed before they leave the hospital, okay? But because of all this, they sound very nasally and very congested, right? If you can imagine your nose here gets all plugged up and you had surgery in your sinus area, it gets very, very, very congested, okay? Now, this is the ICU versus the NSU post-op care orders. As you can tell, these procedures typically do go to ICU first. They really have to do really strict Q1 or Q2 neural checks, okay, about vision. They have to watch the vital signs because the blood pressure cannot go too high, because if they bleed into the sinus and pituitary area, you can have a post-op hematoma and then push on the nerves, the eye nerves, and then that's it. They're completely blind, So they have to be very, very, they have to be very carefully monitored during this type of procedure or after surgery care at ICU. Again, avoid heavy sedations. They are going to have pain. It's more sinus, frontal headache pain that they described. Some people will tell you also, congestion is one, but also watery eyes too. And we'll talk about the expected symptom in a little bit. During surgery, once they go in there, they're looking at the pituitary area. They are also very near the dura too. And sometimes when taking out the tumor, they can have a little bit of a leak, CSF leak. And they do repair it with like a soft tissue graft. They put it up in there, super glued everything. But because you want the wound behind the nose with the CSF leak to heal, very similar to a spine CSF leak where, they have to be flat and only log roll. They put a lumbar drain, right? And lumbar drain typically are in the ICU. They should not come to you guys on the floor, okay? Because again, they need a lot of nursing attention in recording the output and monitor of those drains, okay? And the reason why they put a lumbar drain is because the CSF is very water consistency, so they want to make sure that it goes out through the lumbar drain and not leak through the nose, right? Sometimes they start PTOT at ICU. Sometimes the surgeons will let them up and walk around with PTOT with a lumbar drain. Our PTOT staff in the hospital is aware of drain precautions, so they're very good with that. Sometimes they have DVT chemical prophylaxis. Typically, when we have a lumbar drain, we don't start the sub-Q heparin because of the risk of bleeding. Sometimes they can start the diet right away. Because of that hormone I was telling you guys about with the pituitary called the ADH, antidiuretic hormone, which tells your kidneys to urinate a lot, which goes into a phenomenon called diabetes insipidus, where people are just peeing out large amounts of urine. You can throw off the electrolytes in the body, right? So when patients go through pituitary surgeries like this, that hormone can get disturbed. And if it gets disturbed, they'll have a temporary DI. How neurosurgeons want to kind of manage with them or manage the patients is we'll tell the patient, you just drink when you're thirsty. Because if you're peeing out a lot of urine, the automatic mechanism of your body is that you're going to be thirsty. And so you just drink the water. So we wanted to be able to even out the I's and O's, the ins and outs, right? If they can balance themselves, how much they pee out, how much they drink in to how much they pee out, then their serum electrolytes will be okay. Like it will be very well controlled, okay? These patients are always ahead of bed at 30. It's just easier for the congestion feeling. We start the bowel regimen because we don't want them to bear down because it will increase brain pressure. This is a little different when we talk about Foley care because we need to have strict I's and O's. So we actually have a nursing communication order that says, do not remove the Foley unless it is ordered by neurosurgery team. Because that DI phenomenon I was telling you guys about, it can, throw off a lot of electrolytes and make people really sick. So we really continue Foley maybe about 2 to 3 days until we know that the DI is kind of improving or resolving, okay? Here's out of bed with assistance, nurses, rehabs, You know, cardiac monitoring, again, strict ins and outs, and then double check the labs. There's also another nursing communication order that tells you if there's, you know, 400 mLs of urine that comes out in 1 hour, make sure you get electrolytes checked, make sure you get urine specific gravity, you know, like there's a specific order for that, okay? That sometimes, you know, these ins and outs and labs, the electrolytes check, this Foley, this water at bedtime, that sometimes get carried out to you guys at NSU as well, okay? Let's see, next one. Okay, expected symptoms for a transfemoral pituitary surgery. So patients will complain about congestion. The headaches are described to be frontal, very sinus type. They have watery eyes because, believe it or not, some of the mucus that they feel in congestion from the sinuses, it goes out into their tear duct. They sometimes also complain about postnasal mucus, blood-tinged mucus via nose, and I just tell them to dab it, kind of like a mustache, you know, dressing. I do not want them to blow their nose, okay? One, they probably can't because they have a nasal packing, but I do not want them to blow their nose. So you got to be careful about the nasal packing too, okay? Things to watch for, any CSF leak through the nose. So you guys have to be able to differentiate mucus versus CSF leak, like watery. And sometimes it could be a questionable. So I tell people to dab it with a tissue, and sometimes if it's CSF, we can, you know, see a ring around it, and then you can show it to us when we round, right? If it's a CSF leak through the nose, they may have another symptom called positional headaches, where they stand up or sit up. It's leaking through the CSF is leaking through the nose, and then they get really bad headache. But then the minute they lay down flat, then the headache goes away, and then the leak stops. You know, so you can have positional headaches. Patients also can complain about excessive thirst, which if you look at the urine output, it might be high. We also have to check on the electrolyte imbalance as well. And then obviously still neural symptoms change, any visions, any, you know, one-sided weakness, you know, and also vital sign changes as well. All right, now going to cervical spine precautions. I'm sorry, cervical spine procedures. Here's some indications here: degenerative disease, trauma, tumors, infections, hematomas. So we basically have a couple approaches, one through the front, which is the anterior, and then one through the back, which is the posterior. Here's some x-rays, and this one particularly is the anterior cervical discectomy. This disc was removed, and then they put in hardware to secure with the vertebral body. And that's a sagittal view, and this is a anterior posterior view. And then here is another x-ray that has the front view, the anterior view, and then also the posterior view, where the procedure was done with patients facing down, muscles in the back of the neck are cut midline, up and down, dissect the muscles out, and you can tell the spinous process are being removed. That's called the laminectomy. And then they basically put in hardware. These hardware are always titanium and cobalt. Again, they are okay with MRIs in the future, and they're not going to set off any security alarms. Here's some ICU post-op care versus neurosurgery post-op care. Some patients do go to ICU for cervical spine surgery post-op care. But I would say a good majority, 90% of us, 90% of the patients do go straight to you, okay? But there are some differences in terms of the orders here, as you can see. The main thing that I want to point out here, because I'm sure you guys can, you know, read my lectures too as well. The ones in yellow, so these are like drains, right? So either in the wound, the front or the back. Make sure you clarify with the provider if we want to on suction or off suction. And the reason is because if we have a on suction, that typically means that there's no CSF leak. So we want to suck out the any residual fluid from the irrigation or some of the muscle oozing, so that it doesn't become a hematoma over the spinal cord. more particularly in the posterior, okay? Sometimes I'll see some surgeons put a drain in the anterior portion, but they're very superficial, okay? So make sure you know if your drains are supposed to be on suction or off suction, okay? Depending on the procedure, because I have seen recently that some neurosurgeons through the anterior approach, they don't require a neck brace. I also have seen that some of the neck surgeries, the anterior and the posterior, they say the Miami J collar needs to be on only with mobility. In bed or eating, they can take it off. So make sure you get that clarification and parameters as well, because that would really help the patients, right? If the patients can take off the collar during meal time, it's easy for them to swallow. So get that clarification. Our staff, neurosurgery staff, typically know to already put it in for use, just so that you can um, acknowledge and make sure that the patient to be a little bit more comfortable, to comply with the neck bracing instructions. The diets might be a little different from an anterior to a posterior approach. Anterior, when we make a cut, typically on the right side of the neck, when we go into the midline of the cervical spine, we do have to retract the trachea and the esophagus. So after anterior cervical discectomies and fusion patients, almost all of them will complain about sore throat. And then you have to watch for shortness of breath, because that means that the trachea can be in spasms. And we'll talk about the expected symptoms just right here. I think everything else is kind of the same. Okay, so here's the expected symptoms. So if the posterior incision goes up into the skull, some patients will describe, oh, have a headache. Obviously, they have neck pain. And some people will tell you, I have shoulder pain, right? Because the incision in the back of the neck goes up and down, connects to the bottom of the skull and then to the upper shoulder. So some people will say, I have headaches, neck pain, and the upper back pain. These are expected. Again, symptoms depend on the surgery location, right? Sometimes you'll have a laminectomy for amyotomy on the right side. So in terms of cervical spine, if the surgery is only on the right side of the cervical spine, they shouldn't have any left arm weakness, right? Because the symptoms you want to watch for is really more on the right. So you got to think about your location. Anterior approach, a lot of sore throat. Both anterior and posterior patients have a lot of muscle spasms. It doesn't even matter. Like people, if it's anterior, posterior, anytime you smack on a collar, they will have muscle spasms. Very common, okay? So things to watch for: any neural symptoms decline, vital sign changes, bowel and urine regimen, anything with the cervical, anything with the spinal cord, people can have problems with the nerves going down into having their bowels and urine, right? So you got to see if they're having any urinary retention or incontinence. Make sure your blood pressure is less than typically 140, 160. This is, if you notice, a little bit more relaxed compared to the cranial procedures. Make sure you look at the drain functions. Okay, remember what I said, JP valve, if it's full, or Dayval drains. If that canister is full, it's not working. So you want it to suck out the wound as dry as possible to avoid hematomas, to kind of lessen the muscle bruising, okay? Be careful of your falls, right? Spinal cord, maybe they're not as steady, they're probably deconditioned by the time they get to us. So they're really high fall risk. Double check the wound. Typically first 3 days, I don't even touch the wound, but do check the back of the dressing. If it's soaked, let us know. You can reinforce it. And then, send us a message. We can double check. Typically from a surgical team, we check it anyway. Make sure that the collar fitting is okay. In our hospital, PT does the fitting. So if you feel like the collar doesn't fit the patient well, when the physical therapists come, you can kindly ask them to double check the size. And then again, trachea spasms here, you know, shortness of breath, coughing are some of the symptoms. Patients will complain. And then, you know, double check on the wound checks. And then esophageal spasms, usually it's coughing with liquids. So after surgery, I typically do like a very soft diet. I think after over here, I'll say that soft diet. Yeah. That's for anterior approach. I usually tell them to do soft diet for like 7 days. Okay. All right. So next procedure is the thoracic spine procedures. And this is basically the section of your rib cage, T1 down to T2, but in the back. Here's some indications of us, you know, of doing it. Approaches are either posteriorly or anterior, which is a little bit difficult. You do have to do, sometimes they do a lateral position cut here. And then sometimes they do have to go through the front, but a lot of surgeons would have to be involved in order to do that type of approach through the front or on the side. So here's some NSU post-op care, Q2 to Q4 neuro checks. Here's your blood pressure goals here. It's, again, you know, a little lax compared to cranial. Pain control, a lot of pain control here. IV and orals, right? Be careful, or I'm sorry, double check on your drains on and off suction. And in this area, what's different compared to the cervical surgery is that T1, I think anything above T3, we do a CTO brace, which is a cervical thoracic orthotic. So they have a neck brace along kind of with a thoracic kind of like a turtle shell type of brace. Versus anything lower, they can just do a TLSO, which is thoracic lumbar sacral orthotic brace. Typically after fusion, they can put the brace on at the edge of the bed. Like they can sit up and then you can put on the brace. If it's a fracture that has not been fixed, to be on the safe side, you can log roll them into this brace. However, I don't want the nurses and you guys to kind of make that assumption or judgment call, and the PTOT people knows that too. They don't make that judgment call or assumption. They wait for the order. So as providers, we will give you the clarification how to put on the brace, okay? DVT prophylaxis, regular diet, you know, head of the bed at 30. It's more comfortable for this type of procedures for the patients. And then obviously bowel and urine regimen, and then mobility. Here's some expected symptoms. Patients usually say upper or mid back pain. Again, depends on the location, right, of where surgery is. If it's anterior or lateral approach incision, you have to watch. Sometimes patients will tell me, I can't like catch my breath. I can't like take a deep breath because one, incision hurts. So that may be expected, okay? Obviously, muscle spasm is also an expected symptom. So what you guys need to watch for in thoracic spine procedures is any neurological symptoms decline, vital sign changes, bowel urine regimen, blood pressure control, drain care, okay? These people are also high fall risk as well because thoracic spine is also around spinal cord, okay? And then wound bleeding and dehiscence problems too. You know, anytime when we do thoracic or lumbar incisions, I always tell my patients they have to move. I don't want them to like just lay there and, you know, on their back, because that puts pressure onto their incision in the back and they can break down, okay? So I tell them to move. So here's some x-rays here. Here's a thoracic posterior. It's a posterior approach. The screws goes into each vertebral body connected by 2 rods to kind of hold the skeleton or the spine in place. These rods are made out of titanium and cobalt. They're okay with MRIs and not going to set off any security alarms, okay? So here's kind of a before and after where lateral and posterior approach for the thoracic spine was done. So if you can tell, look at this fracture is really compressed. And what they had to do is take out that fracture and then basically put a cage in there. So they had to do more of a lateral approach to get into that as well. Typically, it could be done by thoracic surgery team that will help us. Here's a scoliosis x-ray, and then look how long these rods are. Crazy. This surgery is probably like 6 to 8 hours long. A lot of blood loss during this surgery. They probably have multiple blood transfusions already. And these patients typically go to ICU first for volume check, blood work check, neuromonitoring. If you can tell, like all the spine is being moved to straight. So there's a lot of soft tissue disturbances that we got to watch for. So these scoliosis procedures typically go to ICU first, and then they go to you guys. All right, moving down even further, lumbar spine procedures, okay? Here's some indications: degenerative disease, tumors, infections, trauma, approach posteriorly, anteriorly, like a ALIF, we call it ALIF, right? Here's some NSU post-op care here, neuro checks, vital signs checks, your pain control, again, your drains, watch out for your drain function. In this particular patient population with lumbar spine procedures, we do use the brace called LSO, lumbar sacral orthotics, and this is for fusion. So people don't have hardware placed, just a simple laminectomy or a discectomy, a disc removal. They don't typically need a brace, okay? Bracing, the goal of bracing is really to help the patient to stand upright, because once you operate anywhere around the muscles, front or back, their strength of the core strengthening gets decreased. So the brace kind of helps them stand upright and makes them secure. With hardware placement, the muscle dissection is wider. So there's more muscle weakness that goes along with wider dissection. So that's why they put on a brace. For a lumbar lami versus, or thoracic lami or a microdiscectomy, the dissection of the muscles is not that wide. So you don't need a brace, because every time you brace a body part, you are going to have muscle atrophy. So you don't want to make the patient weaker, right? So I always tell people, you only put the brace on anytime out of bed, because, in bed, they can move around. It's okay. They're not going to hurt anything, because the gravity also takes off of the pressure in the skeleton when they're in bed versus when they're up or sitting. Their gravity is added pressure onto the skeleton. Okay. Okay, so let's continue with lumbar spine procedure, post-op care. So again, head of the 30 degrees flat. After surgery, if it's before surgery and the fracture is unstable, make sure they're log roll flat, okay? Start working on your bowel and urine regimen, okay? Because in this area, the lumbar spine, some people do have a hard time to push because the incision is in the low back, and it's harder to push to go poop. You got nerves around the sacral area too. I'm sorry, you got nerves that tell to go urinate, and numbness in the groin area. So it all depends on the symptoms. So start working on your bowel and urine regimen as well. So again, early mobility, cardiac monitor, you can be discontinued if the vital signs are stable. Some of the expected symptoms for lumbar spine procedures, patients complain upper to lower back and buttocks pain. Again, it depends on the symptoms, depend on the surgical location, and definitely they will always complain about muscle spasms. Things to watch for, right? Neurological symptoms decline, vital sign changes, bowel urine regimen. Some of these patients, because of heavy narcotics use, they have urinary retention. So you got to do your bladder scan, in and out cath. Some people have permanent urinary retentions, cauda-equina syndromes, right? So you have to teach in and out cath. Your blood pressure control, drain care. These people can also be a high fall risk, so be careful with them. And then double check the wounds, okay? Here's some x-rays. On the left, it shows a TLIF, which is called a transforaminal lumbar interbody fusion, where the discs are removed and they put in a kind of a disc spacer, okay? These hardware, again, they're all MRI friendly. They're not going to set off any security alarm. Versus here, which is a lumbar fusion, with the disc is literally, they probably couldn't get into the disc space here, where it's almost bone on bone. But they just kind of put in the hardware and the screws and the rods to hold this two level stable so that it doesn't move when they stand up. Okay, because you can tell that there's a little bit of offset in here. So they put in rods and screws to hold this segment stable and not move. All right, now moving further down, sacral and coccyx procedures. Here's some indications, just to name a few: degenerative disease, tumors, trauma, fractures. Approach typically could be anterior or posterior. You also have the posterior coccyx removal as well. Here's some NSU post-op care orders. You know, again, think about your drain. You know, obviously your neural checks, vital signs, pain control. Here's your brace. If there's hardware in it, put on a brace. No hardware, don't need a brace, okay? Your DBT, your diet, head of the bed, you know, work on your bowel and urine regimen, wound cleansing if it's coccygectomies, because those are very low type of incisions. So, okay. And then cardiac monitoring, early mobility. Expected symptoms: low back buttocks pain. Again, symptoms depend on surgical locations, muscle spasms. When it's incision in the sacral area, really low, you guys got to be, you know, think about urine and bowel dysfunctions, you know, like incontinence of the bowel or incontinence of urine or retention. Here's some things to watch for: neural symptoms decline, vital sign changes, bowel urine regimen. Here's your blood pressure regimens, your drain care, fall risk, and then make sure you clean the wound or check the wound after they use the bathroom when it's really low, like sacral and coccyx, okay? Because we don't want to dirty the wound, okay? Here's some x-rays here. Here's the anterior. Here's the posterior. So this is anterior and posterior both. Again, all the hardware is made out of titanium and cobalt and okay for MRIs and not going to set off any security alarms. Okay, moving forward, and we're going to talk about a little bit about wound types of wounds. And here's some examples of lumbar wounds. Here's ones secured with steri strips. Here's one with nylon sutures, and then here's one with staples. Okay, typically I tell my patients to keep your wound dry for 7 days. Wound people would say 7 to 10 if it's in the back, right? They use Tegaderm, which is a water-resistant bandage, to cover it during shower, and then they remove it. They should check their wound every day to make sure there's no excessive redness or swelling, or discharge. Usually after about 7 days, I let them shower with clean water, not bath. So they cannot soak the wound in a bath, okay? But just shower with clean water and then pad the wound dry, okay? This is a Dermabond type, or glue type of wound. I'm sure you guys been seeing that a lot lately. This type of closure can shower after when they get home, like that night. They don't need to cover with water resistant bandages because they themselves are water resistant, okay? When it is time to be peeled off, they literally look like a snake's skin peeling off. So I educate patients about that because sometimes they freak out, like, oh my God, this is peeling off. Like, this looks gross. What's happening, But I always tell people, do not rub the wound, right? But they can shower without covering it. Here's some wound infection signs and symptoms: redness, discharge, edema, opening, fevers greater than 101. And there's a time frame for this. I get a lot of phone calls, messages from my clinic when people come in after, or they get home from you guys, right? They get discharged, they're in the hospital for 3 days, 2 days they get home, and all of a sudden they have 100.9 fever, but they have no other symptoms. and they're coming back into the ER, and basically it's like, oh my gosh, I have my wound is, I might have an abscess in my, inside my wound. But if you look at the wound looks great, and it's too early for a surgical wound to get infected. So there is a bit of a time frame when a surgical wound can get infected. But I put this out there for you guys just so you guys know. Okay, so here's some key points, okay, from nursing care. So we want to, so basically you guys want to just make sure what is the neuro exam. Read the H&P on the neuro exam. What did the patient present to the hospital with? Did it get worse? If it did, please call us, right? Or document and please call us. Well, how about the vital signs? If it gets worse, please call us too, right? Neurosurgery and spine surgery, we have internal medicine doctor that co-follows with us. So they are just as important to us and should be to you guys as well, and they can help, okay? Make sure we have early mobility, make sure we have pain control. Try to get them on pain control with oral pain meds, because I don't like to discharge people if they're still using Q2 hours of IV Dilaudid or IV morphine, okay? So try to educate, encourage patients, and get their pain control with oral pain medicine, okay? Urine regimen, again, if they need education for some in and out cath or Foley care, we want you guys to teach them early. We want to also educate the patient and family. Bowel regimen is preferred, but definitely they need to pass gas, okay? DVT prophylaxis, dressing changes when soiled. We have to teach them how to, take care of the wounds, change their dressings. I typically like to get patients advocate, either their friends or family on board sooner. So, everybody's on the same page. For drains, if there is a CSF leak, no suction on the bulb. You drain to gravity, okay? Sorry about that. If there is no CSF leak, then we want the bulb on the JP drain and the Davol to be full suction, and we want it to empty out when it's full, right? Remember I said if it's full, it doesn't work. Be careful of the fall risk, because muscles that are disrupted for surgery may also cause mobility issues, okay? You want to make sure the nutritional intake is good, whether if it's through the mouth or a G-tube or a PEG. Your head of the bed positions, if it's for CSF leak, thoracic and lumbar areas, we have them flat and you turn patient every 2 hours. If it's a cervical CSF leak, we have the head of bed at 30. These orders should be clarified for you guys, okay? If it's not, you ask the provider. And then lastly, make sure you turn patients and double check for pressure ulcer injuries. Make sure that you check for drain pressure injuries as well. Make sure you check for neck collar and shoulder pressure injuries when they have a brace, All right, somebody asked me to do a little bit, kind of like a brief discussion on Chiari malformations, because I guess sometimes the Chiari malformations go to NSU staff. So here's the definition. Basically, Chiari malformation is a structural defect from the base of the skull and the cerebellum, and then basically extends below the foramen magnum, which is like a hole, okay, that enters into the cervical canal. So, here's an example here. Hold on, let me see if okay, so here's some symptoms. You guys can read that over. Headache, neck pain, hearing, sometimes hearing and balance problems, dizziness, vomiting, curvature of the spine, difficult swallowing, some breathing problems, just some symptoms that you hear patients to complain about. Now here is the MRI anatomical difference, okay? So here's a normal MRI. This is called a sagittal view, looking at the side of the patient. Here's the nose, here's the mouth, here's the brain, here's the cerebellum. Here is the brainstem down the spinal cord. And that's the foramen magnum, the opening that goes from the brain down to the cervical spine canal, right? So for a Chiari malformation, you see how tight this is? where the cerebellum kind of goes downwards, is pushing on the brainstem, and it's like this opening is actually really tight. So this is kind of like herniating down. And if you can imagine, that can cause a lot of symptoms, right? Because your cerebellum has to do with balance. You got nerves that come out of these brain stems. So hence you have all these symptoms that can happen. There are different types, 1, 2, 3, 4. You guys can read about it yourself. There's some other type of associated conditions with Chiari malformation, because ultimately Chiari malformation is a condition that people are born with, okay? So, so hydrocephalus, spina bifida, these are other type of conditions that can be associated with it. How do we diagnose it? We start with a brain MRI without contrast. Sometimes the surgeons will order with contrast to make sure there's no tumor growth, okay? They will order a CT scan without contrast to look at the ventricles to make sure there's no hydrocephalus. The classic definition of Chiari 1 malformation is any herniation greater than 5 millimeters below the foramen magnum. So you take the foramen magnum here, and then you put your ruler or your marker down at the bottom where it's herniating, and this part has to be more than 5 millimeters thick. So there are non-surgical treatments. Sometimes people find this by incidental findings, so we just monitor with annual MRIs or any symptoms. We can treat symptoms with medications, like if it's just headache or whatever, we'll do it with pain medicine. From a surgery standpoint, we do what's called a posterior fossa decompression. This is where the patient is face down. We basically pin the head, and it's attached to the table here. Then we go and make a middle neck dissection. And then we open the dura. So here's the skull, and here's like the shoulder here. And then we open the dura, and then we put a synthetic dura over here. Okay. And then we put glue on it. Okay. So the reason why we do this decompression is basically we open up the hole posteriorly in the back to allow room for the brainstem and the cerebellum. So it's not pushing on the brain tissues. Okay. The goal is to stop the progression of the changes in the anatomy. That's the goal, okay? Here's some definitions of what syringomyelia is: pseudomeningocele, myelomeningocele. Okay, so I have some arrows to point to you that. Sometimes people will show up with these kind of cystic lesions there, but then it'll get cut off for some reason, or this will extend down to the thoracic spine, but then we will scan up here in the skull base area to make sure they don't have a Chiari malformation first. Because in order to treat this, sometimes it's as easy as doing the posterior fossa decompression procedure, and then all these serines will get better by itself, okay? Pseudomeningocele can still happen after the posterior fossa decompression. And basically what that means is the fluid of the CSF is coming out of the repair, but it's underneath the skin. You see that? So that's something that you guys need to watch for. Okay, hence right here, pseudomeningocele. Okay. So some of the expected symptoms for Chiari malformation: skull base headaches, neck pain, upper back pain. Again, depends on where you have the surgery, the symptoms may arise, but a lot of muscle pain, spasms, here. Things to watch for: a neurological decline, so like walking problems, arm symptoms, these are basically routine for you guys. Typically, we do not put a drain here because we put the glue. We put the synthetic dura, right, to allow room. And then we put the glue to repair the dura so it doesn't leak. The CSF doesn't leak out. So we don't put drains here. But because of that, you might have to check the back of the wound and feel around the muscles, make sure it's not fluid. And double check the island dressing to make sure it's not wet, because we don't want CSF to come out, okay? We don't typically put a neck brace because there's no hardware. But sometimes if they put a hardware like a C12 area, then you do have to put a neck brace. But typically we don't put hardware in carry malformation surgeries. All right, so this is a craniectomy. This is someone asked me to talk about that. So craniectomy is removing a skull bone, a part of it, to allow the brain swelling to expand without squeezing the brain tissue. The bone can be either housed in a pocket subcutaneously in your stomach, or they can put it in a freezer, or they can just throw it away. At Kaiser LA, if we do have something like this, we typically throw it, either put it in the stomach or we throw it away, because Kaiser LA pathology department does not have license to freeze body anatomy. So, but other medical centers, like usually trauma centers like Northridge, and maybe Cedars, I think they both have freezers. But typically our neurosurgeons don't like to transport them here because we didn't do the surgery, so we don't know the infection risk of that. So we typically have to make a brand new skull bone. All right, and then there's indications for craniectomies. Usually it's traumatic brain injury, strokes. We do craniectomy in the skull for carry malformations too. So here's some CTs. You can see this is a bone here. The white circle is a bone, and this part is removed. You see this dark gray area. It's probably a stroke, and there was a lot of swelling. And then usually with time, like a couple months, you'll see a divot, right, in the defect of the skull. And that means all the swelling kind of just got better, improved, right? Here is a swollen brain here, like very, very swollen. So that probably is this. ICU, oh, these patients typically go to ICU first, okay? So, so here's some orders for that. Typically we have a subgaleal drain or subdural drain, depending on why we did it, why we did the craniectomy. Very similar to the craniotomy orders. For you too, as nurse NSU nurses, the orders are very similar. Sometimes they may still have a subgaleal drain. Sometimes they don't. Be conscious that these type of patients with the craniectomies, they may need a helmet for mobility and rehab assessment. So if they gets transferred to a nursing home in an ambulance, they should have a helmet on because they have no bone in that area. I do see a lot of nurses put a sign and it says no no skull bone on the right, and then they typically move the patient on the side where it does have a skull. So do not lay patient on the side without the skull bone. So these are probably a few main differences that you guys need to be aware of. Okay. Expected symptoms: headaches. Symptoms depend on the surgical location. Seizures can be a risk here, okay? And then medication side effects, be careful with that. Like don't heavy sedate them. Things to watch for. Main thing is, besides the typical neuro and vital signs and seizures, if they still have a lot of brain swelling, we want the serum sodium to be a little bit upper, like 140, 150. If they're on hypertonic saline, which is 3%, on the floor with you guys, make sure we have Q6 serum sodium check, okay? Usually if the serum sodium is above 150, then we stop the hypertonic and then we wait for the next 6 hours of the serum sodium check. Blood pressure is less than 140 here. And then again, just watch for the consistency of the drain output and then how much is it. We don't want to over drain the CSF because sometimes CSF will come out through here too. And then double check on the wound. Make sure there's no discharge coming out of the wound or dehiscence. And then avoid putting the patient on the side or lay on the, like if it's a right craniectomy, don't lay the patient on the right side. Make sure they lay on the left side. And then double check for skin wounds, pressure wounds, okay? All right. Let me see. The indications for this. So repairing for cranial defects caused by previous injuries or operations is decompressive craniectomy, filling the defect area, usually a piece from the bone, synthetic material. I want to show you this picture right here. This is a synthetic material. So when I do cranioplasty CT scan, they're scanned in a very thin slice, and I send it off to a company that Kaiser contracts with, and they actually make a skull model here, and they actually make this defective piece. So we usually don't do this cranioplasty procedure until about a couple months afterwards. It is an elective procedure. It does not improve neurological symptoms. So patients typically will have to be functional. They have to recover to a functional state in order for us to put this back on. Okay. Here's some, we call it titanium mesh that we have in the operating room, and we can put that on too. As you can tell, it's not very cosmetically sound, right? Because it just doesn't look like a good bone here. Cranioplasty is, putting the bone back on, and here's some ICU post-op care. They shouldn't come directly to neurosurgery unit. They should go to ICU first and then come to you, because there are things that can happen with cranioplasty placement, such as epidural hematomas, subdural hematomas if the dura was really bad. So they need neuromonitoring, okay? Same thing as the craniotomy type of orders. By the time they get to you, the main difference, besides the subgaleal drains, if they do still have it, is that once the skull bone goes back on, they don't need helmets anymore. Okay, so they can do PTOT without helmet. Some of the expected symptoms, very similar to the craniotomies, headache, scalp pain. They sometimes have facial edema as well, okay? Seizures also be a risk here, even though it's just like a bone, plate replacement. Things to watch for, very similar. Look at this serum sodium check. Now I'm lowering it to 135 to 145, because by this time I'm putting on the bone, they're actually recover from the cranial condition, right? Blood pressure less than 140, double check the drain output. Same thing, wound dehiscence, just double check with that. Okay, so now we're gonna go into the drains. Why do we need it? So the purpose of the drain is really to remove excess fluid, to alleviate pressure and lessen the dead space. It depends on the type of the fluid and how much the minimum maximum. Like if it's typically blood, I would say, okay, it's fine, just let it come out, right? Because we don't want to worsen the muscle bruise, and we don't want to cause a hematoma around the nerves, okay? But if it's like CSF-y, like in the brain or by the brain cranial stuff, then we don't want to have a lot of like CSF fluid like coming out, sucking out from the cranial portion. So it just all depends. Here's some example here I just talked about. There's a few types: subgaleal drain, subdural drain, EVD, I mentioned earlier, subfascial drain. So the subgaleal drain is under the scalp above the skull. Subdural drain is under the dura above the brain tissue. And the EVD drain is where the catheter is inside the ventricle. You measure the ICP, intracranial pressure, with the system, okay? And then there's a subfascial drain where the catheter is under the fascia, such as the JP or Davol. You guys typically see a lot of this type of drain in the spine portion. If the bulb is full, it doesn't work. I want to talk a little bit about real quick about the wound vacs. On the left side is more of it's called the Provena, I think, here in our hospital. Basic, and then the right one is like more conventional. So basically, the reason why we have this type of wound system is for patients that have high risk for wound breakdown. And what these systems do is that they create a negative wound pressure, so they suck the skin really tight, whether if it's nylon or staples or nothing, we don't put glue underneath on these wounds because then it won't work. So it has to be either nylons or staples or steri strips to be underneath these wound vacs, and what it does, they create a negative pressure, and then it helps the skin to come together so it heals nicely. This conventional, or the Provena stays on for 7 days and then off. Okay, we don't take this off every day. It's really painful to put it back on. The conventional wound vac is usually for wound dehiscence. If you look at this picture right here, the black is a sponge, and then this is like a big wound. And maybe because the patient just have really a lot of, medical comorbidities, so we can't take them to repair the wound. We put a biofilm here, and I'm sure you see the wound specialist nurses on the floor too. They connect to a catheter, and then this machine sucks out the drainage. And basically what we want is we want the wound to heal from inside and out, right? We talked about the purpose, we talked about the indication here. And that concludes my slides and my lecture. I thank you for your time. It is a lot, I understand that, but if you see me around, if you have any questions, feel free to flag me down. I'm always around. I love to teach. I love taking care of patients, and I love being your support. Okay. Thank you, guys. This will conclude my lecture. Bye.